It is a hot topic, and I've got lots to cover, so I'm going to get to the housekeeping right away so that I can move on to the more interesting stuff. Oh, it works. Okay, so here's my disclosures. This presentation was developed at arm's length independently of any commercial interests. Cannabis, I will be discussing the off-label use of cannabis. It hasn't gone through the usual regulatory processes. There is no DIN number for it, so technically all uses are actually off-label. So I've listed here the objectives, which you can read. We are going to talk about the endocannabinoid system, which you may not have heard of. We're going to talk about the potential uses as part of the supportive therapy in cancer patients, and we'll look a little bit at the evidence base that we have. So everybody loves a good case history, and I'm going to start out with that. So Mr. F, I'm going to call him Fred, is a 50-year-old man who died last month under my care on the palliative care unit. And clearly not a gyne-onc case, but I think that this case nicely illustrates some of the general principles that can be applied to most cancer patients. So back in 2010, Fred was diagnosed with an anaplastic glioma following a grand mal seizure. He underwent a craniotomy, a left temporal lobectomy, and a course of chemotherapy and radiotherapy. And then about 4 years later, his MRI showed disease progression, and he underwent another round of chemotherapy. Unfortunately, a year later, again, his MRI again showed disease progression, for which he was treated with yet more chemotherapy. And then in October of 2015, more bad news on his MRI, and he was treated with another round of radiotherapy over 18 sessions, and then continued to decline functionally and neurologically, and sadly, last month was admitted to my unit and with a decreased level of consciousness and died 5 days later. Now, when Fred's tumor recurred, he had a number of issues that he had to deal with. And first off, his wife left him as soon as he was diagnosed and took the 4 kids with her. This, along with his inability to work and his inability to drive because of his illness, led to, not surprisingly, to a clinical depression. He suffered nausea and poor appetite, both as a result of his chemo and as a result of his advancing illness, as well as recurrent seizures on the frequency of about once or twice a month. Later in his illness, and particularly after his second round of radiotherapy, he had some word-finding difficulty and episodes of agitation. Now, Fred had been a recreational cannabis user prior to becoming ill, and in September of 2014, he asked his treating doctor whether he felt that cannabis might address some of his symptoms, and his doctor answered that he didn't know enough about it, but that he really didn't feel it was a good idea. So some 15 months later, he finally got referred through his radiation oncologist to a cannabis clinic. He got an authorization to use medical cannabis, and he started inhaling regularly several times a day with noticeable improvement in several parameters. His mood improved and lifted with cannabis. He would become more talkative, more interactive, more engaged. He had less nausea, his appetite picked up, and interestingly, his word-finding difficulty seemed to dramatically improve immediately after inhaling cannabis, and his speech would become more fluid, and lastly, his agitation was better controlled. So keep this in mind, because we're going to come back to Fred at the end of my talk. So to talk a bit about the plant itself, a cannabis plant is made up of some 450 different chemical compounds, and of these, 200 are found in the plant's resin and broken down into 3 broad categories: the cannabinoids, the terpenes, and the flavonoids. So over 110 plant-based cannabinoids, or what we call phytocannabinoids, have been identified, and of these, THC and CBD are the best known and the best studied. The terpenes give us that unique marijuana aroma, and while both the terpenes and flavonoids may have medical properties of their own, I'm going to focus on the cannabinoids. So THC is the main active ingredient, and it's responsible for the very well-described psychoactive effects of THC. It's also the main therapeutic compound and appears to have effects as an analgesic, as an antiemetic. It seems to have antispastic activity and seems also to stimulate appetite. But in recent years, there's been a lot of interest in another cannabinoid, cannabidiol, known as CBD. And while it's not considered as active as THC, nonetheless, research is indicating some fairly diverse potential therapeutic effects, which I've listed on this slide here. Now, it's also been shown to attenuate and to offset a lot of the psychoactive effects of THC. So that's led to a lot of interest in cannabis strains with a ratio of THC to CBD approaching 1:1, and even strains of almost pure CBD with no THC in them, or almost no THC. So the interaction of the many compounds in cannabis has given rise to a theory known as the entourage effect. And the basic idea here is that the many cannabinoids, as well as the terpenes and the flavonoids, seem to act together and may have a certain synergy, working together to form a kind of metabolic entourage that seems to be responsible for the bioactivity of cannabis. So in other words, the whole seems to be greater than the sum of the parts. And that might explain why a lot of patients tell us that herbal cannabis seems to give better relief of their symptoms than these synthetic cannabinoids do. So starting in 1988, our understanding of how THC works started to be clarified with the discovery of the CB1 receptor. And this is a G protein coupled receptor that's found mostly in the central nervous system of all vertebrates. It's activated by cannabinoids such as THC and a few others that we're going to get to in a minute. But what wasn't clear at the time of its discovery was why all vertebrates would have a receptor for a compound found in a particular plant. So this mystery was solved in 1992 when research discovered naturally occurring cannabinoids, which we call endocannabinoids, and these bind to these cannabinoid receptors, and so far 5 endocannabinoids have been discovered. Then in 1993, another receptor was discovered, known as the CB2 receptor. And in a nutshell, the endocannabinoid system, or the ECS as it's commonly called, is made up of the CB1 and CB2 receptors, the endocannabinoids, and the enzymes that synthesize and degrade the endocannabinoids. So what does it mean, and how does it all work? Why is it important? So CB1 receptors are highly expressed in the brain and in the spinal cord and are 10 times more numerous than the mu-opioid receptors, which are the receptors responsible for the effects of morphine, for instance. In fact, CB1 is the most abundant receptor in the human brain. These receptors can also be found in lower concentrations in peripheral organs and tissues. But on the other hand, and this is kind of interesting, the very, very low distribution of CB1 receptors in the brainstem, and particularly in the cardiorespiratory area, may account for the lack of cannabis-related acute fatalities and its apparent safety in overdose. And in fact, there is no known LD50 for cannabis and no recorded deaths as a result of cannabis overdose. CB2 receptors, on the other hand, are widely distributed in peripheral tissues, particularly in immune tissues, and they've been found in mast cells and blood cells as well. So here's a simple illustration of how this all goes down. Cannabinoids are the major physiological activators of the CB1 and CB2 receptors, and they act as retrograde messengers. So in the central nervous system, the endocannabinoids are synthesized on demand, released from postsynaptic cells, and then they travel across the synapse where they bind to CB1 receptors that are located on the nearby nerve terminals. And then this activation of the presynaptic CB1 receptors leads to inhibition of the release of a number of both excitatory and inhibitory neurotransmitters. Now, in the same way, exogenous cannabinoids derived from either synthetic cannabinoids or from the phytocannabinoids from the plant also enter the bloodstream, diffuse across the blood-brain barrier, and then bind to and activate these same CB1 receptors, mimicking the endogenous cannabinoids and regulating neurotransmitter release. So, in addition to being a target for the endocannabinoids, the receptors are also a target for the plant cannabinoids. And because of the abundance and distribution of the receptors, excuse me, endocannabinoids have been implicated in a wide variety of our body's processes, as I've listed on this slide here. So I've got metabolic craving that's felt to be involved in homeostasis, pain, anxiety, I can't read my slide, it's like too low, bone growth, immune function, lots and lots of processes, and we seem to be discovering more all the time. So there's 3 major groupings. We've touched already on the endocannabinoids. Now, with respect to the purely synthetic cannabinoids, we only have nabilone on the market now. Dronabinol is no longer on the market. And I've listed nabiximols in this group because it is a pharmaceutical preparation, but it's not technically a synthetic and is in fact a pure plant extract delivered in an oral mucosal spray with a 1-to-1 ratio of CBD and THC. And again, phytocannabinoids are those that we find in herbal cannabis, of which THC and CBD are the best studied. So how do patients take it? There's a few different routes of administration, and each of them have their own unique pharmacokinetics. And generally speaking, most patients are either going to inhale it or they're going to ingest it, either in the form of oils or baked into edibles. Now, it's important to note that the oral route has a much, much slower onset, a lower peak concentration, but also a much, much longer duration of action compared to inhalation. With respect to inhalation, patients should always be encouraged to vaporize rather than to smoke in order to avoid the potential carcinogens found in smoke and to minimize any pulmonary complications. And nabiximols spray is a good example of an oral mucosal option, and rectal and topical preparations can also be made, but it's important to note that here in Canada, the licensed producers are only allowed to produce and sell either dried cannabis in a range of potencies or cannabis oils, which are also available in a range of standardized potencies. So, seeing as how I'm addressing an oncology crowd, let's focus our attention more specifically on the role of cannabis in the cancer population. So admittedly, there is a lack of large-scale phase 3 trials, but there is a growing body of evidence for the role of cannabinoids that we're seeing in preclinical studies and as well in a number of small randomized double-blind placebo-controlled studies. So most of these studies so far have looked at either synthetic cannabinoids or purified cannabis extract, and a few small studies have looked at inhaled cannabis. Now, on the other hand, for what it's worth, we have a large body of anecdotal evidence attesting to the efficacy in cancer patients. And while anecdotal evidence is certainly not the gold standard, I don't think we can either completely discount it when so many patients are telling us that this seems to work for them. And I hope that their experiences can guide us in the direction of future studies. But clearly what we need are larger, properly designed and executed clinical trials that can verify the signals and the results that we're seeing in a lot of these smaller studies. So this is a list of the most common symptoms and their prevalence in cancer patients. And here what I've done is I've highlighted the symptoms which may be responsive to cannabinoids. So as you can see, it may have a role in potentially alleviating pain, anxiety, nausea, and anorexia. So what I'm going to do is I'm going to look at these 4 symptoms and some of the evidence that we have in each of these areas. So let's start by looking at an observational study of the use of cannabis in a single institution. Now, this study was published in 2015 in the Journal of Pain and Symptom Management and took place in Israel at an academic medical center. And during the 1-year study period, 279 of approximately 17,000 patients received a permit for medical cannabis. The majority of these patients had metastatic disease, and of the 279 patients, 113 were alive and using cannabis 1 month after approval, and 69 of these patients completed the detailed questionnaire. More than 90% used cannabis by smoking, and what the study showed was that a majority of patients reported symptom relief, and most reported no side effects. Of those that did, the most common were fatigue and dizziness. So this is a graph, and what you see here is that 70% of the respondents reported improved pain, 50% reduced nausea and vomiting, 60% improved appetite, 44% reported reduced anxiety, 70% improved general well-being, 83% reported a high overall efficacy of cannabis. So again, just an observational study, but the data supports the view that the use of cannabis may perhaps be considered in selected cancer patients as part of the supportive treatment. So with respect to pain, there's some fairly robust preclinical evidence demonstrating the analgesic effect of cannabinoids, but again, less data for the use of these compounds in actual clinical pain. But again, a number of small randomized double-blind trials which do seem to indicate in recent years that cannabis seems to outperform placebo in chronic non-cancer pain, particularly in the setting of neuropathic pain. So there's been a few systematic reviews of these randomized trials that have been conducted in the last decade or so, specifically looking at cannabinoids and pain. So let's take a look at a few of these. So this one was published in JAMA in 2015 and looked at 28 studies involving 2,454 patients. And the cannabinoids in these studies included inhaled cannabis, nabilone, nabiximols, and dronabinol, amongst others. And 12 of the studies looked at neuropathic pain, and the 3 of the studies involved cancer pain. So generally, these studies showed improvement in pain measures associated with cannabinoids, with a greater number of patients reporting at least a 30% reduction in pain compared to placebo. And interestingly, the trial that had the smoked THC actually reported the greatest beneficial effect. Now, this review by Lynch and Campbell came out in 2011 and looked at studies that were published between 2003 and 2013, which compared a cannabinoid with a placebo or an active control group in subjects with chronic non-cancer pain. And 18 studies were identified, of which 15 involved neuropathic pain. The quality of the trials was deemed excellent and involved a total of 766 participants. And the cannabinoids that were studied in this included smoked cannabinoids, nabiximols, and synthetics. So in 15 out of 18 of these studies, cannabis showed a significant analgesic effect. Several trials also noted some significant improvements in sleep. Treatment effects were generally modest, adverse effects were mild and well tolerated, and the review concluded that it is reasonable to consider cannabinoids as a treatment option in the management of chronic neuropathic pain with evidence of efficacy in other types of chronic pain as well. Then in 2015, there was an updated review, again by Lynch, along with Mark Ware, and using similar criteria, they looked at 11 trials that had been published since the last review, comparing cannabinoids against either a placebo or an active control group in patients with chronic non-cancer pain. And again, the quality of the trials was excellent. A total of 1,185 patients enrolled with pain conditions that involved both neuropathic and non-neuropathic pain. And the cannabinoids that were studied in these trials included smoked and vaporized cannabis, nabilone again, nabiximols, and oral cannabis extract. So what they found was that 7 out of the 11 studies demonstrated a significant analgesic effect for the cannabinoids, and several trials again reported improvements in sleep. Again, the adverse effects were mild to moderate and were well tolerated. And if you take the findings of both reviews together, there was a total then of 22 out of 29 randomized controlled trials showing that cannabinoids demonstrate this modest analgesic effect, that they seem to be safe, and a reasonable treatment option for chronic pain. Now, while the effect appears to be modest, keep in mind that this is similar in degree to pretty much all medications we have out there for chronic pain. The main limitations of these findings, as in that first review, were that they were small studies, they were of short duration, and clearly what we need are larger and longer trials to confirm these trends that we're seeing and to assess long-term safety. So in 2014, the Canadian Pain Society published their updated and revised consensus statement guidelines in the treatment of neuropathic pain. We know that a lot of our cancer patients have neuropathic pain. And what's interesting here is that cannabinoids actually moved up the ladder from a fourth-line agent in the previous 2007 consensus statement to now a third-line position after opioids and ahead of agents such as methadone and SSRIs and a few others. The guidelines were based on quality of evidence and of analgesic efficacy, side effect profile, and ease of use. And medications were considered to be second or third line if there was high quality evidence of efficacy, but the medication required more specialized follow-up and monitoring. The guidelines stated that cannabinoids are analgesic agents with increasing evidence of efficacy in neuropathic pain states with a number needed to treat of 3.4. And briefly, I'm just going to mention that there is some emerging evidence suggesting that cannabinoids may actually augment the effect of opioids. Synergism between cannabinoids and opioids has been demonstrated in a number of animal models, and a few small human studies have also supported this hypothesis. So with the evidence seeming to suggest a cannabinoid-opioid synergy, it may well be that the co-administration of cannabis is opioid-sparing, which would obviously be beneficial for our patients in terms of limiting opioid doses and reducing opioid toxicity and opioid-related side effects. So I'm going to move on to nausea, and I'll remind you that both dronabinol and nabilone were first marketed for the indication of chemo-induced nausea and vomiting. So in 2001, this review in the British Medical Journal looked at 30 randomized studies involving 1,366 patients. And they looked at comparisons between cannabinoids with placebo or against other antiemetics for the relief of chemo-induced nausea and vomiting. And what they found was that the oral cannabinoids, these studies only involved oral cannabinoids. And what they found was that the cannabinoids were slightly more effective than other antiemetics, but only for moderately emetogenic chemo. But what they also found was that although there were more side effects with the cannabinoids, nonetheless, relatively few patients withdrew because of the adverse effects. And moreover, overwhelmingly, patients seemed to prefer the cannabinoids for future chemotherapy, which suggests that the adverse effects were considered to be minor compared with the benefits, or possibly that the high or the euphoria might in fact be a positive beneficial experience for patients during chemotherapy. In 2006, Ben Amar published a meta-analysis that reviewed the therapeutic potential of cannabinoids. There were 15 controlled studies with 600 patients in which nabilone was compared to a placebo or an antiemetic, and overall was found to be significantly superior to the active comparators for chemo-induced nausea and vomiting. And again, patients clearly preferred the nabilone for continuous use. Then there were 14 studies with 681 patients with dronabinol, in which dronabinol was found to be equivalent or superior to the active comparators. And again, note that none of these studies in either of these reviews compared cannabinoids against the 5-HT3 receptor antagonists, which weren't around at the time of these studies. Then more recently, JAMA published this review of 28 randomized trials with 1,772 patients, of which the large majority of the studies used nabilone, dronabinol, or oral THC, and one study involved nabiximols, the spray. And I've listed here the active comparators. All studies suggested a greater benefit of cannabinoids against both active comparators and placebo, but not all the studies reached statistical significance, but there was certainly a trend there. So while these reviews looked at oral cannabinoids and seemed to find them of some benefit, I should mention that inhaled cannabis has some obvious advantages here, particularly in the nauseated or vomiting patient, including the fact that they don't have to be taken orally. The effect is almost immediate, and patients are more able to tightly titrate the dose of inhaled cannabis because of its very, very short duration of action compared to the oral cannabinoids. So I'm going to move on to the effect of cannabinoids on appetite. And we know anecdotally that patients will report an improved appetite with cannabis, as we saw again in that Israeli study, which I pointed to earlier. But we don't have any clinical trials that actually look at herbal cannabis as a treatment for cancer, anorexia, cachexia. So we'll look at a couple of recent studies that have come more recent studies that looked at oral cannabinoids in cancer patients. So in 2010, this randomized double-blind study looked at oral THC against placebo over 18 days in 21 patients with advanced cancer. Compared with placebo, the THC-treated patients reported significantly increased appetite, improved and enhanced chemosensory perception, that the food seemed to taste better, increased appetite, increased protein intake, and interestingly, increased quality of sleep and relaxation. And the adverse effects were the same in both the treated group and the placebo group. In 2002, this randomized double-blind study looked at 469 patients with advanced cancer, and they looked at oral THC against megestrol and versus combined therapy. And what they found was that megestrol was superior to the cannabinoids, with increased appetite in 75% of patients and weight gain in 11%. But nevertheless, the oral THC did result in an increased appetite in 49% of patients. Combined therapy didn't seem to offer any additional benefits. And it's worth noting also that the dose of THC in this study was really quite modest at 2.5 milligrams twice a day. And then lastly, this randomized placebo-controlled study was published in 2006. This looked at a cannabis extract and dronabinol in 243 patients with cancer, anorexia, cachexia, and they found that neither was better than placebo with respect to appetite or quality of life. So there's sort of conflicting data here. Again, I will tell you that what I see anecdotally in my population is a lot of patients reporting improvements, and it's worth considering that it may just be the reduction in nausea alone that patients report with cannabis that may lead to improvements in their appetite. So next up, with respect to anxiety, the role of cannabinoids for anxiety hasn't actually been studied in phase 3 trials, but epidemiological studies have demonstrated that the most common reason for sustained use of cannabis is to reduce feelings of stress, tension, and anxiety. And anecdotally, a lot of users will report decreased anxiety. And again, harking back to that Israeli study from before, 44% of the patients reported decreased anxiety and 70% reported improved general well-being. Now, the synthetic cannabinoids very typically produce sedation and decreased anxiety as a secondary effect, and in clinical trials of both smoked and oral cannabinoids, Euphoria and mood elevation are very, very frequent outcomes. And there's some really interesting preclinical research in animal models suggesting that the endocannabinoid system might be involved in the regulation of anxiety. We know that the amygdala is hyperactivated in anxiety disorders, and drugs like benzodiazepines work by dampening down this amygdala activity. And there's a fair bit of preclinical evidence that cannabinoids seem to work similarly by reducing anxiety by suppression of amygdala activity. There's also some very interesting emerging scientific evidence of the role of CBD alone in a number of animal studies and also in a few small human studies involving acute experimentally induced anxiety. So I'm going to move away from management of symptoms, and I'm going to talk for a couple of minutes about something that you may or may not have heard of, and that's the potential role of cannabinoids as anti-neoplastic agents. And if you haven't already had a patient ask you about this, then it's just a matter of time before you do, because God knows they're asking me about this all the time. So this is kind of interesting stuff. Cannabis's anti-cancer effect was first noted in lung adenocarcinoma models in the 70s. And since the late 90s, there's been a large body of a large body of evidence accumulating, demonstrating that various cannabinoids will demonstrate an anti-tumor effect, both in vitro and in vivo, in a wide variety of experimental models of cancer, ranging from tumor cells in culture systems to genetically engineered mice. The evidence from these preclinical studies suggests that the effects, again, are both in vitro and in vivo against a number of different cancers that I've listed on the slide here. Now, the exact mechanism of impaired tumor progression seems to be at different levels. The most prevalent effect is the stimulation of apoptosis and the inhibition of cancer cell proliferation, and studies have also demonstrated that cannabinoids inhibit angiogenesis and block invasion and metastasis, and as an added bonus, they seem to preferentially target malignant cells while sparing normal tissue. So again, all preclinical stuff, no human trials yet to speak of, but kind of fascinating stuff, and who knows, perhaps someday there'll be a role for cannabinoids in conjunction with current chemotherapies. So just to summarize, the discovery of the endocannabinoid system has led to an understanding of how cannabinoids work in our bodies and the role of the endocannabinoid system in regulating quite a number of our systems. Clearly, there's a need for larger and longer phase 3 trials to support these signals that we're seeing in the smaller studies. But we have limited evidence so far supporting the use of cannabinoids for some of the symptoms that we see in the cancer population. And compared with a lot of the other medications that we're using in oncology patients, the side effects of cannabis tend to be reasonably acceptable. The adverse effects are well described, and I'm not suggesting that it's a magic bullet, because nothing is, right? But I would encourage you to at least consider it in your patients, because it might cover a lot of bases. It might limit the need for polypharmacy and limit some of the toxicities that we see from the 5 or 6 or 7 or 8 other medications that we're giving patients for symptom control. Now, before I finish, I'd just like to point out that Current Oncology has published this month, hot off the press, a supplement which is entirely devoted to cannabinoids in cancer care, with some very, very respected experts in the field contributing articles, and you might be interested in taking a look at this. And, all right, so you remember Fred that we talked about at the beginning of this talk. Now, I want to get back to him for just a minute. I'll remind you that about 1.5 years before he died, he approached his doctor about cannabis, and the doctor's answer was that he didn't know much about it, but he did not think it was a good idea. Well, wrong answer. Instead of just dismissing it out of hand, what he really should have said was, I don't know much about it, but let me refer you to a doctor that does in order for you to have a proper evaluation. Okay, so here's the thing. It's okay to say no to a therapy that isn't right for a patient, but it's not okay, and it's never okay, to say no because you don't know enough about it and you simply can't be bothered to find out. So Fred finally got an authorization from another doctor 3 months before he died, with good results as far as his symptoms were concerned and with a definite improvement in his quality of life. But had he had access some 15 months earlier when he first asked about it, he would have had a better quality of life for a much longer period of time. So I guess the take-home message here is that if you're not comfortable with cannabis, that's fine. Or if you don't feel knowledgeable, that's fine. But then refer your patient to somebody who is, because I think your patients deserve at the very least that. And then finally, I'm just going to leave you with this quotation, which I kind of like, from Dr. David Yerlink, who is a very well-respected internist and the head of the Division of Clinical Pharmacology and Toxicology here at Sunnybrook. He says, the discussion about medicinal cannabis is one our patients will bring to us whether we want it or not. As physicians, we should not reject cannabis as a medicine simply because it makes us uncomfortable or invoke concerns about effectiveness and safety without acknowledging that the other drugs we might prescribe carry similar and often heavier baggage. Nor should we accede to every request for medicinal cannabis as if it were an innocuous panacea. It is not. Instead, we should do what we do every day, make treatment decisions in a patient-specific context after balancing the risks and benefits of the available options. If we do that thoughtfully, prescribing cannabis will sometimes be the right thing to do. So thank you all for listening. I know I've talked a mile a minute, but I had so much I had to get through. There's a lot I couldn't cover in the scope of a 30-minute lecture, and there's my contact info. If anyone wants to get in touch with me, I'll be happy to correspond with you and answer questions on more practical dosing guidelines and things like that.